Hi, it's Conrad Fisher. Our next section is valvular heart disease. Mitral stenosis. The definition of mitral stenosis is thickening of the mitral valve leaflets from fusion of the commissures and the chordae tendineae. Mitral stenosis is most commonly from rheumatic fever. Mitral stenosis is therefore very uncommon in the United States, and almost always the people you'll see it in are people who are immigrants. People are immigrants from countries where they have less access to care, and the possibility that as children they had rheumatic fever. This largely means from a lack of access to antibiotics. For instance, a pediatric resident in the United States might see one case of rheumatic fever in a year, maybe none. Because what we have is a problem with the overuse of antibiotics, not rheumatic fever. The mitral valve leaflets become thickened and fibrotic, and rarely it's a congenital defect, and 2/3 of the patients affected are women. The pathogenesis of mitral stenosis is that the mitral stenosis impedes left ventricular filling. It's not a problem with left ventricular emptying. It's a problem with left ventricular filling. It's a filling pressure defect from fibrosis of that lesion, and that makes it so that the heart, since it cannot fill, the left atrium is going to dilate, and all the problems happen from left atrial dilation. When the left atrium dilates, that's when you start to get the clots, because you get stasis, and you get dilation, and you get AFib, and because you get stasis and AFib, you get clots, and you get embolic phenomena, and that's why the left atrial pressure goes backwards into the lungs, and that's why we get pulmonary congestion. That's why we get hemoptysis. And this is why we get impaired forward cardiac output, because we end up having all the blood built up backwards in the lungs. Mitral stenosis builds up slowly over years. You don't get symptomatic till you're 20 or 30 years past, at least 10 years past your acute rheumatic fever. You get your rheumatic fever when you're 10, and then you get your valve disease when you're 20, 25, and 30. Just in time for you to have those babies. Don't forget to look for pregnant ladies, because when you are pregnant, you get to be 50% increase in your plasma volume. But the mitral valve doesn't change in size, but you get a 50% increase in the plasma volume, and that's why mitral stenosis so often becomes symptomatic during pregnancy. You get shorter breath, you get shortness of breath, gets worse when you lie flat, orthopnea. The blood accumulates in your chest when you lie down, that's paroxysmal nocturnal dyspnea. The short of breath, and also you get tired, because how can you not be tired if you can't get blood to move forward? The hemoptysis is because the blood vessels become engorged and then they pop. Enlarged left atrium, emboli. Enlarged left atrium, pressing against your recurrent laryngeal nerve, hoarseness. Enlarged left atrium, pressing against your esophagus, dysphagia. Enlarged left atrium, resulting in emboli, AFib, clots shooting around your body. And the back pressure of blood goes back into your liver and makes a big liver, big spleen, big ascites, big edema, and big hemorrhoids. Because of the atrial fibrillation, you're going to have a much greater likelihood of clots. There's Ralls, but Ralls is not unique to mitral stenosis. Any form of congestive failure from valve disease gives Ralls. The decreased pulse pressure, and the loudest one is because of the slamming of the mitral valve. The EKG will show right ventricular hypertrophy if there's pulmonary hypertension, and is nonspecific because right ventricular hypertrophy is from any cause of pulmonary hypertension. You can have left or right atrial abnormalities, again from back pressure, and you should expect to see most often an enlarged left atrium and atrial fibrillation. That left atrial enlargement can be seen on an X-ray as straightening of the left heart border, straightening of the left heart border, lifting up the left mainstem bronchus, a lifting up of the left mainstem bronchus, straightening of the left heart border, and a double bubble, a second density behind the heart, which is the atrium. Curly B lines are fluid in the interlobular septa. When the fluid is outside the lobes, it's a pleural effusion. When there's fluid outside the lobules, it's curly B lines. Get increased vascular markings as you would from anybody with congestive failure. Echocardiogram is certainly what the most important thing is to evaluate valve disease. Echocardiogram is not the most accurate. What is the single most accurate thing to evaluate valve disease? The single most accurate test is the catheterization. Left heart cath. I didn't say it was necessary. I just said it was the most accurate. Echocardiography is going to show those abnormal thickening mitral valve leaflets and calcification if it's there for a long time. Now that key word, is it calcified or fibrotic? Calcified or fibrotic is incredibly important because if it's calcified, you can't balloon it. You can't balloon calcium. But if it's just fibrosis, you can calcify that. So you can balloon fibrosis, but you have to replace the calcium. You balloon the fibrosis, you replace the calcified. And the echo will show the left atrium being enlarged. Mitral stenosis treatment, diuretics and salt restriction. Salt restriction and diuretics are simply for symptomatic relief. They do nothing to impair the pathophysiology of this disorder. They do nothing to slow down the disease. They don't do anything except take fluid out of your lungs. Digoxin, digitalis are to slow down the heart if there's atrial fibrillation, because after all, when does the ventricle fill? Systole or diastole? The ventricle fills during diastole. And when you have rapid AFib, you shorten diastole. So what you do is you use digoxin to slow the rate, so to give time for the ventricle to fill. And only if there's AFib do you use anticoagulation with warfarin. Dabigatran and rivaroxaban are not approved for valvular AFib. Dabigatran and rivaroxaban, as of this recording, is not approved for AFib from valvular heart disease. They're exclusively for non-valvular AFib. Non-valvular AFib. Because valvular AFib, does it have a higher or lower chance of recurrence? Higher. Because that valve problem's not going away. And warfarin is what's approved for valvular AFib. The treatment is that for patients who are asymptomatic, despite medical therapy, you got to balloon it. Pulmonary hypertension is not a contraindication to the balloon, it's an indication. Open it up, unscrew the locks from the doors, unscrew the doors themselves from the jambs. Let's open up your heart, huh? It's poetic, it's practical, balloon it. Balloon valvuloplasty, valvulotomy, those words are used interchangeably, valvulotomy and valvuloplasty, or balloon dilation, and replace the ones that are too calcified to balloon. Mitral regurgitation. Hey, it's our next valve lesion. Yay! Mitral regurg! I like to swim in my mitral valve and black flow of blood from the left ventricle into left atrium because it's insufficient or regurgitant. Oh, who cares? It means the same thing, insufficiency and regurgitation. Mitral regurgitation is caused by ischemia and infarction and infarction and infection and infarction and infection and infarction and infection. And when you have infection, it rots the valves and they separate and you get regurgitation. When you have infarction, you dilate up the heart. And you know what happens? When you dilate up the heart, the leaflets separate. They don't get tighter, the leaflets separate. So hypertension eventually will dilate up the heart. CHF dilates up the heart. Ischemia dilates up the heart. Cooper's ligaments don't get tighter as we get older, do they? No, they don't. They loosen up and they get droopy. And you might say, hey man, rheumatic fever. You just said it caused mitral stenosis a minute ago. Yeah, because it can do both. Rheumatic fever most often causes mitral stenosis, but can do anything. Any cause of dilated cardiomyopathy changes the leaflets so that they will dilate up and get regurgitation. The etiology of mitral regurgitation is any acute rupture of chordae tendineae, acute rupture of papillary muscle. That's the infarction part, and endocarditis is the infection part, infection and infarction and infarction and infection, infection and infarction, and remember that rheumatic heart disease can do it as well, because rheumatic heart disease can also cause aortic stenosis and aortic regurgitation too. Mitral valve prolapse may cause mitral regurgitation, but you're not symptomatic from it as regurgitation. Mitral valve prolapse causes palpitations and pain. Pain, palpitations, panic disorder. Pain, palpitations, panic, prolapse. And as it calcifies up, your annulus shrivels back and creates looseness. Now, when you don't know who to blame a problem on, and you have a problem, who do you blame your problems on? Why, that's what we have parents for, to blame our problems on. So congenital cardiac disease. You have a problem, don't know who to blame it on? Guess what mom and dad are for? Let's blame it on mom. Congenital. Same as fibroelastosis, congenital. The bottom line is anything that dilates equals regurgitate. Dilate, regurgitate. Oh, my heart is widening, but my leaflets are not tightening. My heart is widening, my leaflets getting loose. Regurgitate. In mitral regurgitation, a portion of the left ventricular stroke volume is pumped backwards into the left atrium. It results in increased left atrial pressure and decreased forward flow. Well, you can't have it go both ways. It can't be going backwards and forwards. It goes backwards. This overload occurs and you get increased preload into the left ventricle. Now, the afterload eventually changes too, but the major issue in mitral regurg is its simple backwards flow of blood. The left ventricle will eventually start to dilate up, and when it does dilate up, the ejection fraction goes down, and you treat it like congestive failure. The symptoms of mitral regurgitation are the symptoms of classic left ventricular failure: dyspnea, apnea, paroxysmal nocturnal dyspnea, edema, ascites, anorexia, fatigue, I'm tired, and pulmonary hypertension, which doesn't have a direct symptom except the things I just said. The physical findings are that you have the signs of left ventricular hypertrophy, a displaced PMI. You can get a diminished and brisk carotid upstroke. Well, carotid findings are not that important except for high-bounding pulses when you have aortic regurg and pulses parvus, tardus, diminished and delayed with aortic stenosis. That's the only time that they really make a difference. What makes the difference the most in mitral regurgitation is you got a holosystolic murmur, holosystolic or pansystolic or holosystolic or pansystolic murmur, and you have mitral regurgitation with a holosystolic murmur obliterating both S1 and S2. S3 happens when you have rapid ventricular filling, which you do because of the sign of fluid overload. And like all forms of fluid overload, mitral regurgitation gives you distended neck veins, especially when it's severe and acute, the same as you would with anybody with pulmonary edema. The electrocardiogram shows both left ventricular and left atrial enlargement. Left ventricular enlargement is an S in V1 plus an R in V5 greater than 35 millimeters. An S in V1 and an R in V5 greater than 35 millimeters. And left atrial enlargement shows a biphasic P wave in lead V1. Okay, left atrial enlargement and lead V1. And cardiac enlargement, where you have, again, left ventricular hypertrophy enlarging out to the left, and vascular congestion. For all valve lesions, echo first, cath is best. Echo first, cath is best. And although the mitral valve may prolapse into the left atrium, remember, when we say mitral valve prolapse, that's not what we mean. We mean mitral valve prolapse. That is specifically a syndrome of pain and palpitations where the valve leaflets eventually meet, but there is still some regurgitation. In terms of treatment of mitral regurgitation, all valve lesions improve with reducing fluid. They all improve with diuretics. They all improve with salt restriction, but they don't all improve with ACE inhibitors. Mitral regurgitation improves with ACE inhibitors because vasodilation helps the blood to go forward. Vasodilation helps the blood to go forward, and so therefore ACE inhibitors, ARBs, or hydralazine, anything that is a vasodilator, decreases afterload, helps blood to go forward. Digoxin is not as important because you can't sort of undilate the whole system by just giving some digoxin. Diuretics are for symptoms of fluid overload. They don't change the overall pathophysiology. Diuretics do not decrease the rate of progression of the disorder. Diuretics do not decrease the rate of worsening of the disorder. Diuretics are simply to decrease the symptoms of the disorder. The only drug that has a chance of decreasing the rate of progression is the vasodilator therapy to help the forward flow of blood. Once the heart dilates up in size, what can you do to restore it to normal shape and size? Nothing. So once the heart dilates up, you can't restore it. So we need to replace the valve in mitral regurgitation before it dilates up. And how do you do that? Is you look when the ejection fraction goes less than 60% or left ventricular end systolic diameter goes above 40 millimeters. And those are the indications that you're going to get an irreversible widening of the heart. You might say, well, isn't 60% rather on the normal size? Well, yes, it is. But it's like saying that you're going to wait to see if the person hits the sidewalk after he commits suicide and jumps out the window. You say, well, I don't know, he has a free feeling of air under his arms right now. He's jumped out the window. He doesn't feel bad. Yes, but it's the sudden stop that gets us later on. You see, we can't wait until we get to the sudden stop. You have to wait only long enough for the heart to dilate up. If you wait till the ejection fraction comes down to 50%, you'll never be able to fix it. When it comes down below 60, that means that you've got to replace it before it dilates any further. The next subject is mitral valve prolapse. Mitral valve prolapse is a congenital valvular abnormality in young women. It can be associated with connective tissue disorders such as Marfan's. However, most of the time, mitral valve prolapse just happens. Sometimes bad valvular disease happens to good people. It just happens. Most patients with mitral valve prolapse are asymptomatic. As a matter of fact, when the echocardiogram was invented in the late 70s, early 80s, all of a sudden there was like a wave of mitral valve prolapse. All of a sudden everybody had it. Why? Because they were just finding it. It wasn't symptomatic. Now, the question is, when there is symptoms, what's the most common symptoms? Palpitations, that's all. Lightheadedness sometimes. Syncope is rare. Chest pain happens. Atypical pain. Sometimes with exertion, sometimes not with exertion, sometimes at rest. Arrhythmia. But the most common, palpitations. The physical findings are the murmur. It's a late murmur. Mid to late murmur. Click, murmur, click, murmur at the apex. Anything that makes the heart smaller, like Valsalva or standing, makes the lesion worse. Anything that makes the heart smaller, like Valsalva or standing, makes the lesion worse. Anything that makes the heart bigger, like squatting or leg raise, makes it better because it makes it fit. It makes the leaflets fit. When the heart is smaller, the leaflets don't fit and they click. When the heart is smaller and we have click, click. But when the heart is bigger, you don't hear it as much. What makes the heart bigger? Squatting and leg raise. The worst presentation of mitral valve prolapse is an occasional person develops a serious arrhythmia. This is very rare. It's extremely rare, but it has been associated with sudden death. Congestive heart failure is mostly from mitral regurgitation, not so much mitral valve prolapse. Although there is a small increase in the risk of bacterial or infective endocarditis, it's not enough to indicate the need for antibiotics and prophylaxis. So there is the hypocrisy of saying it causes bacterial endocarditis. Yes, is there some indication that there's an increased risk of endocarditis? Yes. Well, what are you going to do about it, fishy fish? Nothing. I'm not going to do anything about it. But you just said it's an increased risk. That's true. But what if I get all my teeth cut out of my head? Do I need to take antibiotics? No. No prophylaxis for mitral valve prolapse. It can calcify if it's very severe over time, but then again, people get calcified valves even who don't have anything. 98% of the time is asymptomatic. A few people are symptomatic. It's atypical chest pain and palpitations. And the other findings are profoundly rare. Arrhythmia, sudden death, CHF, bacterial endocarditis, calcifications of the valve, and TIA. The best initial test to diagnose mitral valve prolapse is an echocardiogram. Welcome to all the valve diseases. Echo first, cath is best. Now, catheterization is virtually never done for mitral valve prolapse. It is simply not necessary because you're not going to replace the valve, so why do it? The answer is you shouldn't. Then why bring it up? Because if the question says, what is the most accurate? It is catheterization. What would I do? I'm not doing a catheterization. There's marked systolic displacement of the leaflets, and the point at which they fit together becomes abnormal. Now, although there's displacement of these leaflets, the bottom line is, all you need to know is, a bigger heart makes them fit. A smaller heart, they do not fit. Echocardiogram is the diagnostic test in 99% of cases. The The majority of cases don't require specific therapy. If they're asymptomatic, they require nothing. They don't need a beta blocker. It doesn't worsen. There's no drug to prevent the progression of mitral valve prolapse. There are people who have regurgitant lesions like mitral regurg and aortic regurg. Even without symptoms, you need ACE inhibitors in many people to prevent progression. Even without symptoms, you should be replacing the valve when the heart starts to dilate or the ejection fraction comes down, even if they are asymptomatic. Mitral valve prolapse, no symptoms, no treatment. No symptoms, no treatment. Now, when there is symptoms like atypical chest pain, we use beta blockers for the chest pain. So when there's atypical chest pain, we use beta blockers for that chest pain. And virtually never do we need to replace the valves. It would only be in the most profoundly symptomatic person with markedly worsening regurgent lesions. Next subject is aortic stenosis. Well, aortic stenosis is a very common valvular disease that happens as we age. And people have calcification. The calcium leaves their bones and it enters their aorta and calcify and degenerate those lesions. Bicuspid valve degenerates and calcifies more. Point about knowing it's bicuspid. What are we going to do differently? And the answer is nothing. All we know is that if it's bicuspid, it's more likely to get worse. Well, what are you going to do differently about it, fishy fish? Nothing. Calcifies, it fibroses, and happens more in a congenital bicuspid valve. Bicuspid valve presents earlier because of the anatomic abnormality. And rheumatic heart disease can cause any valvular abnormality. Rheumatic heart disease can cause any valvular abnormality, including aortic stenosis. The pathophysiology of aortic stenosis is that you get increased left ventricular systolic pressure. There's left ventricular hypertrophy. Sometimes it dilates, sometimes it doesn't. At the beginning, first of all, it just hypertrophies. And then later on, the ventricle's like, I'm getting tired, I'm doing all the work here, look at that lazy right ventricle's not doing anything. And then eventually the left ventricle would dilate and get fat and sloppy. It says, the right ventricle's not doing anything, I'm doing all the work in this relationship, I'm going to become as fat and sloppy as the right ventricle. And then eventually it will dilate. So it goes through a sequence of first it hypertrophies, then it dilates. So the stroke volume is maintained normal for a long time. And the forceful contraction can make a left ventricular thicker, and the atrium contracts into a thickened left ventricle, and that's an S4 gallop. Atrial systole into a stiff, non-compliant ventricle. Atrial systole into a stiff, non-compliant left ventricle. And the end diastolic pressure goes up. Because that's the whole point in aortic stenosis. It's a pressure gradient. The pressure is greater in the ventricle than in the aorta. That's the pressure gradient of aortic stenosis. That's the disease, chiquititas. So do you think a hypertrophic wall needs more oxygen or less oxygen? What do you think? Well, a hypertrophic wall needs more oxygen. First of all, there's more meat to supply, so it needs more oxygen. Second of all, the thicker the wall, the less likely it is to be fed by blood. A thicker wall needs more oxygen and is harder to perfuse because the thickened wall impedes the flow of blood to that ventricular wall. The thicker wall has a greater demand and less supply, more pressure. Now, the decreased coronary diastolic filling also can lead to angina pectoris because there's still compression, even in diastole, because it hypertrophies. After all, when do coronary arteries fill? During systole or diastole? Coronary arteries fill during diastole. And the left ventricular pressure goes up, and you can get congestion. But it's all related to an increase in pressure. Which is more costly to the heart? Pressure work or volume? It's pressure. Pressure work is more costly to the heart. The symptoms are angina, syncope, and shortness of breath with congestive failure. Which of these is the most common? The most common of these symptoms is angina. 50 to 70% of patients with aortic stenosis have coronary disease. So you have diseased vessels. Number 2, the stenotic aortic valve is in the way of their filling. The aortic valve is right in the way of the coronary cusps. So you can't fill the coronaries. So angina is is the most common. You have diseased vessels with a greater obstruction to flow into them. Syncope happens, but syncope is not as bad as congestive heart failure, because once the heart starts to dilate up in size, what can you do to restore it to normal size and shape? And the answer is nothing. Once it starts to dilate, you're really gonna die. The carotid pulse becomes diminished and delayed and diminished. Pulsus tardus as parvus, parvus at tardus. Tardus means late, parvus means diminished. A thrill is an abnormal vibratory feeling that happens from severe murmurs. So you can get a carotid thrill when you have an abnormal vibratory sense from too much murmur. And there's this harsh systolic murmur in the aortic area, which is the second right intercostal space, and it radiates to the carotids. And that question says, where does aortic stenosis radiate to? Aortics radiate to the carotids, and mitrals radiate to the axilla. Mitral radiates to the axilla. Aortic goes to the carotids, and mitrals radiate to the axilla. As for Gallup, because there's left ventricular hypertrophy. The A2 is decreased and delayed because normally it's A2, P2, A2, P2, and now it becomes P2, A2 as the aortic valve becomes slower. And then the aortic ejection click. The left ventricle is doing all this work, so the EKG shows left ventricular hypertrophy because the left ventricle is doing all this extra work, and therefore the chest X-ray shows an enlarged heart, pulmonary congestion. But it's all valvular heart disease. All valvular heart disease can show pulmonary congestion because anything that results in increased backflow of blood will result in pulmonary congestion. And when it's there for a long time, and especially in the elderly, it'll be calcified because the calcium leaves your bones and enters your blood vessels. The echocardiogram is the best initial test. It shows you the answer, shows you the specific diagnosis. The leaflets are thickened. There's decreased excursion and movement, left ventricular hypertrophy. But the most accurate test is, of course, the catheterization. Now, unlike the other valve diseases where catheterization may be the most accurate, but we don't do it, cardiac cath is done routinely aortic stenosis. So if the question says, which of these is most likely to need cardiac catheterization, the answer is aortic stenosis. And that's largely because you need to know if there's coronary disease before you replace the valves, because there's so much coronary disease that we might want to bypass the coronaries at the same time we got your chest open. So catheterization prior to aortic stenosis repair or replacement is routine. As bad as it is, there's no endocarditis prophylaxis for any one of these valve lesions. Endocarditis prophylaxis, aortic stenosis, no. Mitral stenosis, no. Mitral regurg, no. Mitral valve polyps, no, no, no. On the endocarditis prophylaxis story, we only do endocarditis prophylaxis if there is injection drug users, yes, with previous endocarditis, prosthetic valves, transplants with valvulopathy, previous endocarditis, prosthetic valves, transplants with valvulopathy. Yes, there's not that much indications for this anymore, except for prosthetic valves, previous cardiac transplants with valvulopathy. And who's got unrepaired cyanotic heart disease? Who is this person with unrepaired cyanotic heart disease? These little blue children they leave running around there? Well, if you have a little blue child that you've left unrepaired, yes, you should also give them endocarditis prophylaxis, but that's the only four. Unrepaired cyanotic, previous endocarditis, like an injection drug user who had endocarditis, transplant recipients with valvulopathy, and prosthetic valves. Now, the overall treatment for aortic stenosis is that you have to replace the valve. You can't balloon aortic stenosis well because balloons only work for fibrosis. Balloons don't work well for calcification. You replace aortics and you balloon mitrals. You replace aortics and balloon mitrals. The only time to balloon an aortic is when it's so severe and somebody can't tolerate surgery and you can't do surgery. The only time to balloon it is when you can't do surgery. Surgery is clearly number one. Let's look at the other things that might be confused with aortic stenosis. Well, there's the word sclerosis. Now, the word sclerosis can easily be confused with stenosis because, after all, they both tend to happen in the elderly, and they both sound the same. They both sound with S, and end with S, and begin with S. Sclerosis basically means thickening, but not actual calcification. You could think of it as very mild and early stenosis. And it's a systolic murmur, and there's no delayed upstroke because it's not severe, and there's no left ventricular hypertrophy because there's a thickening but not actual obstruction to the flow of blood. You might say that it's an abnormality without hemodynamic impact. That's what aortic valve sclerosis is. It's thickening of the leaflets that's abnormal without hemodynamic effect. Sclerosis. Like thin hair without balding. HOCM. There is a brisk bifid carotid upstroke, and there's a murmur that gets worse with Valsalva, worse with standing. It's the same as mitral valve prolapse. Less blood results in more murmur. Now, the thing about HOCM is that the most common presentation is not sudden death. The most common presentation is, in fact, shortness of breath. Syncope is less common, but the least common is sudden death. Mitral regurgitation is holosystolic, meaning pansystolic, meaning it goes through the whole of systole, and mitral regurgitation radiates to the axilla. The carotid upstrokes are normal, but there's dilation of the left ventricle as well. The major issue is that the aortic valve is normal, but you're not going to mix it up because mitral regurg is a pansystolic murmur that goes to the axilla, and aortic stenosis is a crescendo-decrescendo that goes to the carotids. Pulmonic stenosis is a rare entity. And the murmur doesn't radiate into the neck. It's louder in the left sternal border. All right-sided lesions get worse with inspiration because when you inhale, there's more venous return to the heart. More blood, more murmur with those right-sided lesions. And when does the venous return to the right side of the heart increase? Does it increase when you inhale, or does it increase when you exhale? And venous return to the right side of the heart increases when you inhale, and that's why pulmonic stenosis gets worse when you inhale. A physical examination, the chest x-ray and EKG show right ventricular hypertrophy. Sure, because there's increased pressure on the right side, so you get right ventricular hypertrophy. And the echocardiogram will show it as well. Now, what is the most accurate test for pulmonic stenosis? All valve lesions. The most accurate is a catheterization. The auscultatory maneuvers are indispensable for you to know. This is a summary slide, which I'm going to make 2 points on, and then you're going to need to take the time to metabolize it yourself. The bottom line is that anything that increases blood in the heart will result in more murmur for everything except HOCM and mitral valve prolapse. Now, the first thing is, looking across the top of this slide, is Valsalva, which is exhalation against the closed glottis. What does Valsalva do to venous return? Does Valsalva increase venous return or decrease venous return? Valsalva will decrease venous return, so there's less blood in the heart. Phenylephrine is the opposite of amyl nitrate. Phenylephrine and hand grip increase afterload. Phenylephrine or hand grip increase afterload. They're vasopressors, so to speak. So therefore, it's the opposite of an ACE inhibitor. That's why regurgitant lesions and ventricular septal defect, which normally would get better with an ACE inhibitor, will get worse with phenylephrine and hand grip. Phenylephrine and hand grip are the exact opposite of amyl nitrate. That's why if you look at the amyl nitrate column, you'll see that everything in the amyl nitrate column is evenly the opposite of the phenylephrine and hand grip column. Squatting and leg raise do exactly the same thing. Squatting and leg raise should generally do the same thing, because they both increase venous return to the heart. More blood, more murmur. Less blood, less murmur. More blood is with squatting and leg raise. Less blood is with standing and Valsalva. More blood, more murmur. Less blood, less murmur for everything except HOCM and mitral valve prolapse. Aortic regurgitation. What's the etiology of aortic regurgitation? It is systemic hypertension causing that heart to dilate up. Ischemic heart disease. When you infarct the heart and it dilates and the leaflets separate as well. Infection and infarction and infarction and infection. And for aortic regurg, the same as it was for mitral regurgitation. Now, aortic regurgitation is different because there's other lesions that also cause aortic regurgitation. The things that are associated with HLA-B27, like Reiter's syndrome, syndrome and ankylosing spondylitis. Syphilis that dilates the aortic root with syphilitic aortitis, and Marfan syndrome and other connective tissue disorders like Marfan's, Ehlers-Danlos, mixed connective tissue, cystic medial necrosis. Cystic medial necrosis, Marfan's, Ehlers-Danlos, and a very stretchy guy you have there. Rheumatic heart disease can cause any valve lesion. Rheumatic fever can cause any valve lesion. And so can dissection. Slice it back and slice it through that aortic valve. Aortic regurg results in volume overload of the left ventricle. The heart starts to dilate. It goes off the Frank-Starling diving board as it dilates past the point of no return as left ventricular end diastolic volume increases, and eventually you get a decrease in contractility because you overstretch the heart. Acute severe aortic regurg, there's no time to dilate, and what ends up happening is that you get a incompetent valve simply because it's sudden stretch and dilation of the heart. And in aortic regurgitation from valve rupture, what you get is you get a big backward flow of blood and congestive heart failure. Now, in progressive disease, the left ventricular diastolic pressure leads to pulmonary edema because it's a backflow. Well, you know what? Look, it's easy just to say that all valve disease can lead to pulmonary edema and CHF. Valve disease is one of the causes of congestive failure. The fluid goes the wrong way. Aortic regurgitation signs and symptoms are shortness of breath. Shortness of breath is a sensation of decreased oxygen delivery to tissues. In this case, it's related to blood going backwards the wrong way. Aortic regurg probably has the largest collection of unique physical findings. De Rosiers' sign over the femoral area where it's a palpable thrill over the femoral area. There's an S3 because there's fluid overload as the ventricle starts to fill. There's a diastolic decrescendo murmur along the lower left sternal border, a diastolic decrescendo murmur, and systolic flow murmur. The Austin-Flint murmur happens at the apex. There's head bobbing and Det Musette sign. There's Hill's sign as you have a greater pressure in the upper extremities than in the lower extremities. You have Waterhammer bounding pulse, also known as Corrigan's sign, a Waterhammer high bounding carotid pulse. De Rosiers' sign over the femoral area. Boy, oh boy, you get the largest collection of unique physical findings. If it wasn't for step 2, no one would know them. The EKG will show left ventricular hypertrophy with a volume overload because it starts to dilate up the ventricle. And that same dilation is seen on the chest x-ray, dilation of the aortic regurg, and the left ventricle will hypertrophy out to the left. The echocardiogram is the most specific initial test. The echocardiogram will show the dilated left ventricle and aorta and the volume overload, and what you might also see is it flops backwards into the mitral valve leaflet. You might see an echocardiographic version of an Austin-Flint murmur. The bottom line is that color flow Doppler on the echo can see the regurgitant jet of blood. You can hear it along the lower left sternal border. The left ventricle starts to hypertrophy, and people are short of breath. Regurgitant lesions are always treated with vasodilators. ACE inhibitors, ARBs, nifedipine, they're vasodilators. No endocarditis prophylaxis for any of these valve lesions except for prosthetic valves, previous endocarditis, unrepaired cyanotic heart disease, and transplant patients. The medical management is with diuretics and salt restriction and decreasing fluid in the heart. But remember, the only drugs that might decrease the rate of progression are vasodilators. Now, once the heart dilates up in size, you can't do anything to restore it, so you've got to replace that valve before the heart dilates up in size, and that's why the criteria for this one are ejection fraction less than 55% or left ventricular end systolic diameter going over 55 millimeters. 55. Ejection fraction less than 55%, left ventricular end systolic diameter going above 55 millimeters.